Okay, let's unpack this. Welcome back to the deep dive. Today, we are absolutely swapping our comfortable studio chairs for a set of surgical scrubs and stepping right into the orthopedic injection suite.
It feels like it.
Yeah, think of this as the ultimate teaching round. We've compiled a massive stack of clinical sources, a tree surgeon's playbook really detailing the explosion of ultrasound-guided or USG procedures for the knee.
A really important topic.
It is. And our mission today is far beyond just listing facts. We need to synthesize exactly why USG has transitioned from being, a cool optional skill to the unequivocal, non-negotiable gold standard for almost every single knee intervention.
Right.
We'll be detailing the technical setup, the specific anatomy we target, the nuanced agents we use, and most importantly, the hard evidence supporting all of it. This deep dive is intended to be a practical, detailed, in-depth guide for the curious learner, the resident, the fellow, the practitioner, who really needs to achieve true mastery.
And that mastery is now expected.
Exactly. The core thesis, which the literature supports without fail, is that USG procedures provide recognized and dramatically increased accuracy compared to traditional blind procedures. But as we're going to discuss, that accuracy is not just a statistical win.
Oh, not at all. It's the difference between a successful treatment and a clinical catastrophe.
Precisely.
What's fascinating here is how the scope of ultrasound has expanded. You hit the nail on the head. It's no longer just about aspirating a large, obvious joint effusion.
Right, the low-hanging fruit.
Exactly. The source material emphasizes that USG is now essential for every structure adjacent to the tibiofemoral joint. That includes difficult-to-palpate areas like the proximal tibiofibular joint, the often pathologic patellar tendon, the deep, hidden popliteus tendon.
Which is so hard to find clinically.
Impossible sometimes. And the problematic pes and anserinus bursa and complex cysts like a multiloculated Baker cyst or deep ganglia.
So for those working in the field, what was it like before? I mean, we spent decades essentially guessing, right?
We did. Think of it this way, and this is a great analogy for the learner. Performing an unguided injection was like trying to navigate a dense Alaskan forest at midnight using only a crumpled map you found in the glove box.
Okay, I like that.
You might feel a bump and think, I'm in the joint, but you have zero confirmation. Using ultrasound guidance, we've essentially flipped on military-grade night vision goggles. We can visualize the target, the critical soft tissue envelope, the immediate surrounding neurovascular structures, and most importantly, we can confirm the deployment of the injectate in real time.
In real time, that's the key.
That's the key. This translates directly into procedures that are safer, more effective, and crucially reproducible.
That analogy sets the stage perfectly because the clinical mandate for guidance stems directly from that stark, sometimes frightening inaccuracy of the blind technique. So let's talk numbers. The data shows a truly massive chasm here.
It's a huge gap.
USG-guided intra-articular injections, so injecting into the main knee joint space, consistently boast an accuracy of up to 96%.
96%. That's the standard we must hold ourselves to. Now contrast that with the results from unguided injections. Accuracy plummets, sometimes to unacceptable levels.
And the literature gives us a compelling high-stakes example with the pes anserine bursa.
Yes, a structure notorious for its small size and ambiguous location on palpation. Unguided accuracy for that specific bursa often sits around 50%. 50%. With USG guidance, that accuracy jumps to a perfect 100%.
100%. I mean, that's not even a marginal improvement.
It's a different procedure entirely. Let's pause on that 50% figure for a moment. For you, the listener who needs to internalize the clinical implication, if you miss that bursa half the time and you've just injected a potent corticosteroid, what happens?
Well, the patient gets no relief, for one.
For a patient with painful osteoarthritis who might also be diabetic, not only have you failed to relieve their pain, but you've deposited a systemic steroid dose that can cause a dangerous, sometimes prolonged glucose spike. They get zero therapeutic benefit, a metabolic insult, and now require a painful, unplanned reinjection, totally shattering their trust.
Right. That 50% failure rate isn't just a clinical metric, it's a standard of care violation.
It absolutely is.
And the sources detail exactly why that failure isn't just a simple loss of therapeutic effect. This brings us to the morbidity list, the catalog of complications that make that 4% or worse. The 50% failure rate intolerable.
Inadvertent extraarticular injection of any therapeutic agent, whether we are discussing anti-inflammatories like corticosteroids or viscous materials like hyaluronic acid, has immediate and serious consequences. You have reduced therapeutic effect.
So the patient's symptoms don't improve.
Correct. You also dramatically increase post-procedure pain, often because you are injecting volume into tissues that aren't meant to accept it, which immediately undermines patient confidence and adherence to the treatment plan.
And the dreaded cosmetic and clinical failures that we see too often.
Yeah.
Local fat atrophy and skin depigmentation. I've seen that personally.
Oh, yeah, it's a terrible outcome.
That characteristic divot and white spot where the steroid was deposited too superficially, that's a classic visible hallmark of missing the target. You're creating an avoidable iatrogenic problem that the patient lives with long term.
And beyond the cosmetic issues, we get to the critical catastrophic risk, and this is the one that forces the mandate for USG, the increased susceptibility to tendon rupture due to inadvertent intertendinous injection.
That's the one that keeps you up at night.
It is. We are talking about the patellar tendon or the quadriceps tendon, the primary load-bearing structures of the extensor mechanism. Depositing a crystalline corticosteroid directly into the collagen matrix initiates necrosis and weakens the structure. If that patient then returns to activity, the risk of a full-thickness rupture skyrockets.
So if you're injecting near any load-bearing tendon,
you must know exactly where that needle tip is relative to the tendon fibers. There's no other way.
And on the diagnostic side, the impact of a miss is a pure waste. I mean, if we're prepping for a specialized MRI or CT arthrogram and we inject the arthrographic contrast blindly,
and it leaks into the surrounding soft tissue, say the infrapatellar fat pad or a bursa, the study is non-diagnostic.
completely useless.
Completely. The contrast doesn't distribute into the joint space to outline the menisci or cartilage defects. That means a repeat procedure, increased radiation or cost, and a potential delay in critical surgical planning decisions.
Which brings up the financial argument. The clinical and financial arguments are now inseparable.
They really are. Our sources cite studies demonstrating that USG not only increases the responder rate and decreases pain scores, the clinical success, but it also leads to a quantifiable reduction in overall cost per year.
Why is that?
It's simple, because accuracy leads to fewer revision injections, fewer non-diagnostic studies, and maximized therapeutic effect, making the entire episode of care more efficient and cheaper long-term. USG is a cost-effective necessity.
So that's the why. Now let's transition into the how. Let's define the basic technical setup, the resident's playbook, for a simple intra-articular procedure. What are the key steps, specifically focusing on the dynamic visualization that makes the 96% accuracy possible?
We begin with patient positioning, which is critical. The patient is typically supine, and we need to flex the knee to approximately 20 to 30 degrees using a pillow or a bolster.
In why that specific position?
This strategic positioning relaxes the quadriceps mechanism and tends to open up the joint space, often pushing any existing effusion into the accessible suprapatellar and lateral pouches. It just makes your target bigger. We use a high-frequency linear probe, typically 7 to 15 megahertz. When we scan, we're looking for the target, which is the hypoechoic fluid collection, the effusion, if present. If the joint is dry, we aim for the trochlear cartilage recess, deep to the quadriceps tendon.
And what's a common novice mistake here?
Transducer pressure. The critical error for the novice is applying too much pressure. You must apply minimal pressure, otherwise you will compress a small or subclinical effusion, obliterating your target area. You'll make it disappear.
That dynamic scanning before needle entry is key. Once we've pre-scanned and confirmed our entry point, say a lateral parapatellar approach, how do we confirm our path?
The needle pathway is always planned before we breach the skin, often marking the path on the skin itself. We prefer the in-plane approach whenever possible.
Meaning you see the whole needle.
The entire needle shaft, from insertion point to tip, is visualized simultaneously as a bright, linear reflective structure. Hyperechoic. This is the safest way, bar none. As you advance the needle, you watch for the synovial lining. Often you'll see the synovial membrane or the joint capsule tent slightly before the needle tip pierces it.
A little visual cue.
A subtle but important visual cue. Once you pierce the capsule, the tip is in the target. But here's the critical confirmation step, the clinical show-me moment, which is the use of a small test dose of local anesthetic, usually 0.5 to 1 cc.
Tell us what we should see dynamically when we inject that test dose, both when we are correct and when we are wrong.
Okay, when you are correct, you must look for two things. First, minimal resistance. The fluid should flow easily. Second, dynamic visualization of the hypoechoic fluid, meaning the black fluid, rapidly filling the joint space, spreading and ballooning the suprapatellar and lateral recesses.
Like in figure 15.1.
Exactly like that. That confirms you are in the joint capsule. If you see resistance, or if the fluid tracks immediately back up the needle path and balloons the subcutaneous fat pad, or if it tracks deep along the periosteum of the femur, you've missed.
And you can just correct on the fly.
Guidance allows you to correct that micro-movement instantly, which is something impossible with a blind approach.
Okay, so moving inside the joint. The spectrum of use is extensive. We focus on the tibiofemoral joint for both aspiration and injection. Let's quickly review the dual purpose of aspiration.
Aspiration is paramount. Therapeutically, if a patient presents with a large, tense effusion, simply draining that fluid can provide immediate relief and improved range of motion.
And diagnostically.
Diagnostically, aspiration is life-saving. We are sampling for critical etiologies. Is it infective, so septic arthritis, which is a surgical emergency? Is it crystalline, like gout or pseudogout? Or is it inflammatory, like rheumatoid arthritis? The fluid analysis, cell count, culture, crystal identification dictates the entire, potentially immediate management strategy.
And injections, of course, fall into therapeutic categories: steroids, viscosupplementation, biologics or diagnostic categories, like arthrographic contrast. Let's start with the workhorse, the quick fix: corticosteroid injections.
Corticosteroid injection remains the most common and well-established initial treatment for painful flare-ups, particularly in moderate knee osteoarthritis. It's our rapid response anti-inflammatory tool designed to break the cycle of acute pain and inflammation.
But the patient wants to know the lifespan of this quick fix. How long does it last?
And that's the most crucial piece of patient education. While the onset of symptom improvement is fast, often within 48 to 72 hours, the effect is variable and generally lasts only up to 16 to 24 weeks, about 3 to 6 months.
So it's a bridge.
It's a bridge, not a long-term solution.
That seems fast. If the effect is so transient, is the main benefit of the steroid injection truly therapeutic longevity? Or is it almost primarily diagnostic, confirming that the source of the pain is indeed intra-articular before we commit to something long-term and costly?
That is a clinically insightful observation. Often, a steroid injection functions beautifully as a diagnostic test. If the patient gets 90% relief, we know we hit the right target and that the pain generator is the inflamed synovium.
And if it gets zero relief?
We must immediately start looking for an extra-articular source, like a bursitis or a referred pain pattern. This is a subtle but critical role of the quick-acting steroid. Furthermore, USG allows us to visually assess the synovium and effusion reduction over time, giving us an objective measure of therapeutic response.
Okay, let's move to the long-term play. Viscosupplementation. I like calling this the joint's WD-40.
It is exactly that. We're supplementing the mechanical and chemical properties of the joint fluid. Exogenous high molecular weight hyaluronan, or viscosupplementation, has been a staple since its FDA approval in 1997 for symptomatic knee OA in patients who have failed conservative therapies like NSAIDs and physical therapy.
The data around efficacy has always felt a little complicated to me due to conflicting meta-analyses. What is the consensus we should convey to the patient?
The clinical takeaway is balanced. On a population level, it demonstrates a moderate but significant efficacy, maybe 20% better than placebo for overall pain and function. However, the responder rate is high. We see 60% to 70% of carefully selected patients reporting meaningful improvement.
So candidate selection is everything.
Paramount. The critical differentiation point from steroids is timing. Corticosteroids are instant gratification. Viscosupplementation requires patience. The onset of efficacy is 1 to 4 weeks later than corticosteroids.
A whole month later, potentially?
Exactly. But the trade-off is substantial duration. The effects are often maintained for 6 months, and in some long-acting formulations, up to 12 months. This patient education piece is essential. Tell them they will feel worse before they feel better, especially after the initial volume load.
You mentioned the controversy. Why are there discordant findings in the literature, even when we have a high responder rate?
Part of the issue lies in the heterogeneous commercial landscape. The market is saturated with multiple generations of products. Different molecular weights, different levels of cross-linking linear versus reticulated hyaluronic acid derivatives.
Like Synvisc 1, Orthovisc, Euflexa.
All of them. Linear products are closer to the natural fluid structure, but may degrade faster. Reticulated products are thicker and designed for longer residency, but may cause more initial inflammatory reaction or effusion. Analyzing these different structures in one meta-analysis muddies the results.
I see.
Furthermore, if you inject this material into a joint that is actively raging with inflammation and effusion, a hot joint, the cellular environment is hostile, potentially leading to rapid degradation of the hyaluronan and a poor outcome. This is why the optimal candidate, according to the sources, appears to be a patient with moderate tibiofemoral osteoarthritis without significant swelling.
And that's something you can confirm with the ultrasound right before you inject.
Immediately. And again, USG guidance ensures that every molecule of this expensive long-acting agent is deposited directly into the joint space, maximizing its opportunity to work.
Let's move to the regenerative frontier, biologics. This is where innovation and caution collide, starting with platelet-rich plasma, or PRP.
PRP is exciting, but we must remain grounded in the data. Right now, the data is inconclusive. The studies suffer from small sample sizes and a lack of standardized preparation protocols in the limited randomized controlled trials.
So we don't really have a standard dose?
Not at all. We still see wide variability in PRP content. Some clinics use leukocyte-rich PRP, which has higher inflammatory potential, and others use leukocyte-poor PRP. This heterogeneity complicates analysis.
But what's the general trend?
The prevailing direction of findings suggests better outcomes in younger patients with a lower degree of degeneration. Essentially, PRP seems to function best as a biologic boost for repair in early disease, rather than a miracle cure for end-stage arthritis. We are still actively refining the ideal patient, the ideal concentration, and the ideal preparation.
And the mesenchymal stem cells. This often captures the public imagination as the pinnacle of regeneration.
The interest is enormous, particularly in using autologous cells derived either from bone marrow, which is BMAC, or from adipose tissue to promote cartilage and meniscal regeneration. The hope is that these cells can truly repair damaged tissue.
But the efficacy
Remains to be fully established by rigorous, large-scale studies. That's the key phrase that must temper the enthusiasm. The challenge, clinically, is confirming that the injected cells integrate and differentiate into functional chondrocytes rather than simply offering a temporary anti-inflammatory effect.
Still, the guidance is key for getting them to the right spot.
Absolutely. Just like with PRP, USG guidance ensures the precise delivery of these precious harvested cells to the target area, whether that's the meniscal tear or the osteochondral lesion.
Finally, let's wrap up this section by discussing diagnostic procedures. The use of contrast agents for imaging.
Right, so we use USG to inject contrast agents for both CT and MR arthrography. The reason? Improved sensitivity. Specifically, the literature confirms that when intra-articular contrast material is utilized, there is significantly improved sensitivity in detecting subtle or small meniscal pathology.
Particularly after a previous surgery.
Exactly. Recurrent or residual meniscal tears after previous surgery compared to conventional MRI. The contrast agent effectively outlines the defects, making them easier to spot. We also use CT arthrography for detailed, high-resolution assessment of the articular cartilage surface and for evaluating the integrity of osteochondral allograft transplant.
And again, if you miss.
If your guidance is poor and you miss the joint space, you've rendered the entire advanced diagnostic study useless, delaying the surgical decision point.
Okay, stepping outside the joint capsule now, let's focus on soft tissues. This is where USG truly transitions into microsurgery because we're treating tiny disease targets surrounded by high-risk neurovascular structures.
That's a great way to put it. Tendinopathy around the knee patellar, popliteus, ITB, is often chronic, painful, and notoriously refractory to simple rest or medication. USG gives us the ability to precisely treat the localized specific pathology identified on imaging.
Let's start with the most common, the patellar tendon, or jumper's knee. What are the characteristic USG features of this frustrating pathology?
We are looking for classic signs of tendon degeneration, or tendinosis. The normal tendon should look like tightly packed parallel guitar strings. That's the normal fibrillary echo texture. When it's sick, we see disordered collagen matrix.
So what does that look like on the screen?
On USG, this manifests as regions of hypocoicity, meaning dark, water-filled, or disorganized areas, and a loss of that crisp fibrillary pattern. It looks fuzzy, frayed, and swollen.
And you can use Doppler too, right?
We do. If the condition is chronic, we often apply Doppler imaging, which may reveal the angiofibroblastic response. Increased vascularity within the tendon substance. This neovascularization, which correlates with pain, is a specific target for procedures like polydocanal injection or high-volume injection therapies.
Walk us through the procedure for addressing that tendinosis, maybe referencing figure 15.3.
Okay, patient positioning is supine, knee flexed to about 30 degrees for relaxation. We use the linear probe longitudinally, ensuring we see the inferior pole of the patella proximally and the Hoffa's fat pad deep to the tendon. We must scan the entire length.
And for treatment, you're targeting those specific hypotopoechoic regions.
Exactly. Needle fenestration, or dry needling, essentially poking multiple small holes into the tendon, is a well-established technique used to stimulate a healing response. The evidence supports it. One retrospective study on recalcitrant patellar tendinopathy showed that 72% of patients reported excellent or good results regarding their return to activity after fenestration.
That's a highly effective outcome for a condition that typically sidelines athletes. Besides fenestration, what agents are we targeting into these pathological zones?
The options are broad. We mentioned high-volume injections, hyperosmolar dextrose for prolotherapy, buledoconal to target neovessels, autologous blood, and PRP. Crucially, PRP shows robust outcomes here. One study comparing PRP injections versus focused shockwaves in athletes demonstrated significantly improved outcomes with PRP at both 6 and 12-month follow-up.
Suggesting it's potentially superior for long-term healing in this tendon?
It does.
You also mentioned advanced technology like the 10X system. Is that an evolution of fenestration?
It is an evolution toward precise tissue removal. The 10X Health TX system utilizes focused ultrasonic energy delivered via a tiny microtip to mechanically cut and remove only the damaged, disorganized, diseased tendon tissue that we see as hypochoric on the screen.
So it's a targeted percutaneous tenotomy?
Exactly. It's visualized using the same ultrasound guidance techniques, ensuring we debride only the pathology and spare the healthy load-bearing fibers.
Now, for the critical safety caveat, the steroid warning, I want to emphasize this point for anyone considering a blind injection here.
This is a teaching point that cannot be overstated. Corticosteroid injections provide only short-term benefit for patellar tendinopathy, and that benefit is often outweighed by the risk.
The risk of rupture.
The primary danger is the serious risk of tendon rupture. Because we are dealing with a critical, load-bearing extensor tendon, injecting steroids directly into the collagen matrix is an invitation for structural failure. USG guidance is mandatory to ensure that if a steroid must be used, say for a surrounding bursitis, it does not accidentally spill or deposit intratendinously.
So the rule of thumb for load-bearing tendons is
Minimal to no steroid, period.
Let's move to a structure that is often the hidden culprit of refractory lateral knee pain, the popliteus tendon. It's deep and often missed clinically.
The popliteus complex is anatomically fascinating and functionally vital. It originates from the lateral femoral condyle and serves a crucial function in unlocking the knee and maintaining dorsolateral stability. Because it is deep and protected, pain arising from its tendinopathy, it's just notoriously difficult to localize accurately through palpation alone.
Since it's so hidden, the technical approach must be highly specific. What is the optimal positioning and probe placement to visualize this tendon?
We use a specialized position. The patient should be placed in the lateral decubitus position, lying on the unaffected side, with the affected knee flexed approximately 30 degrees and the leg slightly internally rotated.
And that position helps bring it into view.
It tensions the tendon and helps bring it into relief. We place the probe transversely, identifying the lateral femoral epicondyle and the fibular head. The popliteus tendon is seen nestled deep within the groove between these two landmarks.
But the clinical high-stakes element here is the surrounding anatomy.
Absolutely. USG guidance here is not just about accuracy, it's about avoiding the common peroneal nerve, which courses more posteriorly in this region. The needle is pathed in plane, aiming specifically at the superior margin within the tendon sheath or the tendinous substance. This level of dynamic, real-time visualization is not optional. It's necessary for preventing a critical iatrogenic nerve injury.
The common peroneal nerve is just too important to risk with a blind pass.
It's a disaster if you hit it.
Finally, the iliotibial band, or ITB, friction syndrome, the classic runner's complaint that presents as lateral pain.
The ITB is a massive band of fascia formed by the convergence of the tensor fascia lata, gluteus maximus, and medius. Friction syndrome causes pain and tenderness over the lateral femoral epicondyle, often during repetitive knee flexion.
Corticosteroid injections are often employed here, but given its superficial location, what are the unique risks we must manage with USG?
The superficial location presents a dual danger. Firstly, the risk of injecting the tendon itself, which carries that predictable increase in rupture susceptibility. Secondly, because it's so close to the skin, the risk of superficial steroid deposition leading to local fat atrophy and visible depigmentation is extremely high.
A very visible failure on the side of the knee.
Exactly. Strict, in-plane USG care must be taken to ensure the medication goes into the deep bursa, or the interface between the ITB and the bone, and not into the skin layers or the tendon substance itself. We use the probe to create a visual tunnel for the injection.
Okay, moving on to the fluid-filled structures. Let's tackle the pes cernus bursa again, the medial pain generator and the poster child for mandatory guidance.
The pes serenus is the combined tibial insertion point for the sartorius, gracilis, and semitendinosus muscles. Bursitis here is a common source of medial knee pain, often exacerbated by underlying osteoarthritis or repetitive high-impact trauma.
And let's revisit that accuracy data because it is so compelling. The 50% split, 100% split is the strongest clinical argument for USG standardization in orthopedics.
It is the benchmark. The bursa itself may be challenging to palpate, but when inflamed, it's typically seen as a fluid collection that is thickened and edematous, as shown in Figure 15.4. The data conclusively demonstrated that USG guidance achieves a perfect 100% accuracy compared to that paltry 50% without guidance.
If we have evidence that eliminates clinical failure, why would we choose the alternative?
You shouldn't.
Describe the technique for hitting that 100% accuracy mark.
Positioning is key. The patient is placed with the knee in slight flexion and external rotation to relax the hamstrings. We use the probe in a transverse orientation over the posterior medial knee, identifying the 3 separate tendons. We target the bursa itself, which lies clearly defined between the medial collateral ligament and the overlying pes and serenus tendons.
And you just watch the needle go right
In plane, allowing for dynamic visualization of the needle tip entering the fluid collection and confirming the spread of the injectate within the bursa itself.
Next, the Baker cyst, or the popliteal balloon. What's the primary etiology, and why does USG become a critical diagnostic tool here?
Baker cysts are a type of popliteal cyst. They're almost always secondary to underlying intra-articular pathology, most commonly knee osteoarthritis or a meniscal tear. They form because fluid is forced out of the joint through a one-way valve mechanism in the semimembranosus gastrocnemius bursa.
So it's like a pressure relief valve for the knee.
It is. The critical clinical challenge is that a large or worse, a ruptured Baker cyst can present symptomatically like a deep vein thrombosis or DVT.
That's a huge problem.
It causes sudden, significant calf swelling, pain, and redness. USG is absolutely essential for accurate differentiation. It can quickly confirm if the swelling is cystic from the Baker cyst or vascular from a DVT, saving the patient from unnecessary, risky anticoagulation therapy based on misdiagnosis.
And the cysts themselves have different classifications that impact treatment success.
Exactly. We classify them on USG. Simple cysts are thin-walled and anechoic, totally black. Complex cysts are more challenging. They contain internal septations, synovial hypertrophy, or sometimes even loose osteochondral bodies. This distinction matters deeply, as complex cysts have a higher relapse rate after simple aspiration and injection.
Considering the delicate posterior anatomy, aspiration requires a high level of caution. Describe the mandatory safety scan.
The patient is usually position prone. The priority is a safety scan using Doppler imaging. Before needle insertion, we must positively identify and map the location of the critical neurovascular bundle, the popliteal artery, popliteal vein, and the tibial nerve.
You have to see them before you stick the needle in.
You have to map them. This safety margin must be established prior to breaching the skin. The needle is inserted under direct dynamic guidance, making sure the entire tip trajectory is visible as it enters the cyst cavity. Aspiration is particularly challenging once the cyst is ruptured, because the fluid organizes into clotted blood and daughter cysts.
What's the consensus on combining aspiration with injection for Baker cysts?
The standard treatment is aspiration followed by corticosteroid injection. Studies confirm this yields clinical improvement and cyst volume reduction. Symptomatically, the results appear similar to those obtained with a simple intra-articular knee steroid injection.
Reinforcing the idea that you have to treat the underlying problem in the joint?
Exactly. Treating the cause of the fluid is just as important as draining the cyst itself.
Lastly, let's discuss the challenging world of ganglions and parameniscal cysts, the aching nodule that requires precise targeting.
Parameniscal cysts are tightly linked to meniscal pathology, typically associated with horizontal cleavage tears. USG-guided percutaneous aspiration is a safe and highly effective procedure for decompressing these, as you can see in Figure 15.6. It serves as a fantastic, minimally invasive interim therapeutic measure for patients who may not be surgical candidates.
But the range of non-meniscal related ganglia around the knee is vast and anatomically complex.
It is. USG allows us to navigate incredibly complex lesions. We see ganglions with both superficial and deep components, which require careful sequential aspiration. We also see ganglia rising deep from the cruciate ligaments, the ACL and PCL, and various tendon sheaths.
And the rarest and arguably highest stakes ganglion we can encounter is the intraneural one. This demands absolute precision.
Intraneural ganglion cysts are rare, benign, mucinous lesions occurring within the nerve sheath itself. They usually present with symptoms related to compression motor weakness, paresthesias, or pain, most commonly affecting the common peroneal nerve.
And this is where USG aspiration and injection becomes a highly valued alternative to surgery.
It is. Surgical resection of an intraneural cyst carries an exceptionally high risk of fascicular nerve injury and permanent deficit. Guided aspiration offers a safer choice for decompressing these complex lesions, using minimal fluid to reduce the pressure within the neural sheath.
Okay, let's talk about the ultimate tool for definitive diagnosis, particularly when malignancy or infection is suspected: the biopsy. USG takes this procedure from a risky blind stab to a targeted tissue harvest.
Precisely. USG guidance makes soft tissue mass evaluation around the knee incredibly precise. We use both core-needle biopsies to get a good architectural sample and fine needle aspirations for cellular analysis. The goal is to ensure we harvest adequate tissue from the most viable, non-necrotic portion of the mass.
Now, when we talk about osseous or paraosseous lesions biopsying bone or structures adjacent to bone, critical oncologic planning is required.
This is where we shift completely into oncologic principles. If we are dealing with a potentially malignant lesion, the needle trajectory must be meticulously planned. The primary and overriding concern is preventing the seeding of malignant cells along the needle tract.
Why is that so critical?
If we contaminate a compartment outside the eventual planned surgical field, that contamination tract must then be excised during definitive surgery. This can dramatically compromise a planned limb salvage procedure, forcing a much wider, more complex resection, potentially leading to increased patient morbidity or even requiring amputation.
So even a simple biopsy has to follow the rules of a major surgery.
It must adhere to the principles of definitive surgical margins.
The case examples in the sources really drive home the necessity of this guided diagnosis.
Look at figure 15.9. A lesion was initially thought to be a simple ganglion cyst, but USG allowed for a targeted core biopsy, which definitively confirmed the mass was, in fact, a nerve sheath tumor.
A total game changer, diagnostically.
A total game changer. You cannot treat a peripheral nerve tumor like a benign fluid collection. It requires a totally different surgical approach. USG prevented a catastrophic misdiagnosis.
And the diagnosis of myositis ossificans is another example of tissue confirmation being mandatory.
Myositis ossificans, often presenting as a hard, nodular thickening, sometimes in the LTB region, as seen in figure 15.10. While imaging suggests the diagnosis, USG showed marked associated vascularity, which prompted the guided core biopsy. Histopathology confirmed the heterotopic bone formation. In both these cases, USG enabled a definitive diagnosis, preventing unnecessary aggressive interventions.
Finally, we covered synovial assessment. Why would we biopsy the synovium itself?
USG-guided synovial biopsy has been proposed as a reliable, minimally invasive method for histopathologic assessment of knee joint synovium. This is particularly valuable for diagnosing complex inflammatory arthritides, where the fluid sample alone might be inconclusive. It allows us to analyze the actual inflamed tissue itself.
So, to synthesize what we've deep dived into today, the conclusion seems pretty clear.
I'd say it's non-negotiable. USG guidance is now firmly the standard of care for a vast range of knee procedures. We've moved far beyond just the joint space. We've seen evidence supporting its role in everything from targeted viscosupplementation delivery to complex diagnostic biopsies and the high-stakes aspiration of deeply located popliteal cysts.
And the clinical wins they're evident.
They are. The improved accuracy demonstrated by figures like 96% for intra-articular injections and the perfect 100% accuracy for the pen and Serenus bursa translates directly into better clinical safety, a dramatic reduction in complications like fat atrophy and tendon rupture, and predictable outcomes for the patient.
We are no longer navigating by feel.
We are surgically targeting structures sometimes the size of a thread with military precision.
And we covered the necessary clinical nuances of the agents themselves, knowing that steroids offer a rapid but short-lived 16 to 24-week fix, while viscosupplementation requires patience for 1 to 4 weeks but provides maintenance for 6 to 12 months. And crucially, we now understand exactly where steroids are an acceptable anti-inflammatory tool and where they are an outright danger, particularly for high-risk, load-bearing tendons like the patellar and ITB complex. This level of precision is the future, and frankly, it is the mandatory present of orthopedic practice.
Which brings us to a final, provocative thought for you to carry forward. Given the significant, undeniable evidence showing that USG guidance improves outcome, reduces the risk of catastrophic complications like tendon rupture or nerve injury, and even demonstrates a quantifiable reduction in overall costs per year, should blind injection techniques even be considered ethically acceptable anymore?
That's a heavy question.
It is. When a procedure involves known anatomical risks, such as the common peroneal nerve near the palliatus tendon or the critical neurovascular bundle near the Baker cyst, does the evidence mandate USG guidance as the required standard for all routine knee care? It's a compelling case for a definitive professional standard.